All right, everybody. So we're going to be talking about the brain quite a bit in this lecture and the way it's organized, a little bit about the protection, a little bit about the blood supply, and a lot about the cranial nerves that come off of it. When we talk about the development, embryologically, it stems from these three primary vessels. The proencephalon, the mesencephalon, and the rhomencephalon. And from the cephalon, that's going to be from the proencephalon, that's going to be the forebrain. The M in mesencephalon, think of middle, the midbrain. And then the rhom, think of your rump, that's the hindbrain, what's behind. Now, from that, we develop into 5 secondary brain vessels. And the way you can remember those 5 is tel di, that mes met my. Tel di, mes met my. Tel di, mes met my. And this is from superior to inferior. So the telencephalon makes up the largest part of the brain. That's called the cerebrum. The diencephalon means through the brain. That's everything with the word thalamus in it. So it's the thalamus, the hypothalamus, and the epithalamus. And then I said M and M, right? So mesencephalon, M for middle, is the midbrain. And then the metencephalon, is your pons and your cerebellum. And then the myeloencephalon is the lowest part that's protected by C1, atlas, and C2, axis, and that would be the medulla oblongata. Okay, and then those are the main parts of the brain. And then in the center of all that, we have these ventricles or cavities. There's the lateral ventricles, and there are 2 of them, right? There's lateral ventricle 1 and lateral ventricle 2 because there's 2 hemispheres of the brain. There's the left and right hemisphere. So there's 2 chambers or 2 ventricles. They're called lateral ventricles 1 and 2, and it's not specific. It's not like lateral ventricle 1 is in the left hemisphere and lateral ventricle 2 is in the right hemisphere. It's just a very general term. And then it goes into the 3rd ventricle, and then it goes down into the 4th ventricle. Okay. Okay, and in the midbrain is what we call the cerebral aqueduct, which is just a chamber of where the fluid actually goes through. It's like a drain, if you would, and we'll show you that in more detail. Okay, now the development of the neural system, that really starts at around day 18 or so. So after sperm and egg come together, it takes place at around day 18. When we look at the principal parts of the brain, let's see if we can click on this video here, or the actual mapping of it. So here's the diencephalon. Let's see if I can start at the cerebrum first, because that's the largest part, right? So here's the cerebrum, and that's not to be confused with the cerebellum, right? When your bell is rung, that's when you hit the back of the head. So cerebrum, that's what has all these lobes, like the frontal lobe of the cerebrum and the parietal lobe and the occipital lobe, and that's the large main section. Cerebellum back here is balance and coordination, all right? So cerebrum, then we can go diencephalon, that's everything with thalamus, right? Thalamus, and then the hypothalamus, again, thalamus, underneath it, hypothalamus. Then we have the brainstem. And the brainstem is composed of these 3 sections, the midbrain, the pons, and the medulla, from superior to inferior, MPM. Midbrain, pons, medulla. Midbrain, pons, medulla. Here's your pituitary that is in the brain, and it's endocrine. It's got endocrine function, as does the hypothalamus. So when we get into the endocrine system, we will be talking about the hypothalamic pituitary adrenal axis, or we'll talk about the hypothalamus pituitary thyroid axis, or we'll talk about the hypothalamus pituitary gonadal axis. Okay, those are just three main connections. The hypothalamus is going to release hormones that signals the pituitary gland. And remember, the pituitary sits in that hypophyseal fossa. Remember? Hypophyseal fossa. And the pituitary has those two divisions. It's got an adenohypophysis and a neurohypophysis. The adenohypophysis is the anterior pituitary that makes about 7 different hormones. And then the posterior pituitary is the neurohypophysis that just makes ADH and oxytocin, or antidiuretic hormone and oxytocin. And when I say make it, it's really not the right word. Those are actually made in the hypothalamus. They release it. The pituitary releases those two hormones. And then the ventricles are deep in there. Okay? Okay. So again, now here's a real brain. So we can take a look at some of the major landmarks here. Again, we have the cerebrum, which is the largest part of the brain. And it's important to identify when we look at these sections from lateral view, this sagittal cut, it's important to identify what's anterior and what's posterior. So once we see this, that's the cerebellum, that's the posterior. So if that's the posterior, this has to be the occipital lobe of the cerebrum, and this has to be the frontal lobe. And then over here, this would have to be the parietal lobe. Okay, so you have to know anterior and posterior to be able to identify these parts of the brain. Okay, and then we can see the midbrain, the pons, and then the medulla. All right, and then this section here is going to be the diencephalon, which has your thalamus and hypothalamus. And remember, the midbrain, the pons, and the medulla is called the brain stem. And there are cranial nerves that come off of these parts of the brain. So from the medulla, I'm not going to do these in Roman numeral, but you have to know them for Roman numeral. I am going to just draw them out this way. So in the medulla is where we will find cranial nerves 8, 9, 10, 11, 12. And in the pons, we'll find 7 through 5. Okay. And in the midbrain, we will find 4 and 3. And then coming off of the cerebrum will be 2 and 1. Right? So it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Right? That's where the cranial nerves come from. So understanding that is kind of important, because if there's a TBI or a traumatic brain injury and we test these cranial nerves and we find a dysfunction there, it can clue us in as to, well, maybe there's a problem with the nerve, or maybe there's a problem with that part of the brain. So let me assess other cranial nerves that originate in that part of the brain. Does that make sense? Okay. The brain is one of the largest organs, and it weighs about 3 pounds, and it's involved in everything. I mean, it's involved in your sensations, feeling your body, moving your body, memory, your emotions, your decision making, and even your behaviors. We have parts of the brain that are responsible for certain behaviors. Like we know in the in that frontal lobe, but more in like the infraorbital region of that frontal lobe, has a lot to do with addictions and OCD-like behaviors. We know that in the frontal lobe has a lot to do with your decision making, has a lot to do with motivation. It has a lot to do with people who have like the inability to adapt to society, people that aren't driven to go to school to get their master's degree, right? If you're here, you have a pretty good frontal lobe. You're motivated. If you're living in your mother's basement and they're supporting you and you're not working, and you're fully capable of doing that, perhaps it has to do with the frontal lobe dysfunction. Okay, very, very common. The frontal lobe has a lot to do with dopamine as well, which is activated by movement. So movement and dopamine have a lot to do with each other, and so does your behavior. So children that aren't moving very well don't have good development of their brain. Not just the frontal lobe, every part of the brain. It's actually movement that drives the brain's development. And the neural system, including the brain, it needs three things to function. It needs fuel, oxygen, and it needs stimulation. If we have fuel, like glucose, and we have oxygen, and there's stimulation, which can come from learning or come from movement, the brain is going to develop beautifully. Once it's deprived any of those three things, it's going to start to dysfunction. Okay? So, behaviors, very, very big. Perception. I've had patients say to me, hey, doc, my left leg, look at it. Look at how much bigger it is than my right leg. Doesn't it look swollen? And I'll look at it and I just don't see what they see. So I'll take a tape measure and I'll go around the calf and I will show them. Do you see how it says 15 inches here all the way around the girth of that calf? Yes. I'm going to go to your other one. We're going to go in the exact same location and let's go around and let's take a look at that measurement. And we'll look and I'll say, wow, this one too is 16 inches. So your left one is 16 inches and your right one is 16 inches. What does that mean? And I'll have them answer for me. Well, it means that they're the same. How am I correct? They are the same. And then they'll say, but look at how much more swollen that left one is than the right one. Right? So their perception is distorted. So it leads me to believe that somewhere in their parietal lobe, most likely that postcentral gyrus that represents that part of the body being the lower leg, there's certainly a lesion. So I can do work with them, whether I'm using cold laser to try and bring balance to that part of the brain, or provide eye movements to stimulate that part of the brain, or adjustments to drive up to that exact part of the brain and light that up with activity and balance that out. Okay. Frontal lobe is really a lot of higher order executive decisions. I remember I was consulting with one of my patients' children. I won't say children, they're now an adult. And 18 years old, trying to enroll in college, to a community college. Hey, Dr. Lindner, you teach at so many colleges. Can you, speak to our son and, see if you can guide him a little bit in terms of his interest and maybe what his major should be? I said, absolutely, no problem. So we spent about half an hour talking, and it seemed that he was interested in the human body. Whether he wanted to do some personal training to start out with that, get into physical therapy, occupational therapy. He really wasn't sure, personal trainer. And I said, well, whichever direction you're going, you're probably safe to go liberal arts here, okay? Because liberal arts, you can actually change your major and go into anything. If you want physical therapy, occupational therapy, physician assistant, chiropractic, anything in those basic sciences, you're safe to start off with the liberal arts. okay? And then you can always change to, like liberal sciences if you so choose, but at least take these general courses in the beginning. So we fill out the application. It takes about another 20 minutes, so we're almost an hour into it. And he shakes my hand, and as he's about to leave my office, he's like, I'm also thinking about hotel management. Like, what a shift. So it just shows that, until you're about maybe 24, 25, 26, I mean, the frontal lobe is still very immature. It's still developing. He doesn't know. So my advice to so many teenagers, go to a community college at first. Mommy and daddy do not have to spend all their money on an expensive sleepaway camp for those first few years, which is, really what college is when you have these young kids that are growing up and now they're just older kids. If they're not raised like mature adults to make responsible decisions, they don't know how to adapt out there in the world. They've never taken care of themselves. If you've done it the right way and you've trained your children to become mature adults earlier on, there's probably nothing to worry about. But so let them go to a local community college, let them learn about themselves and let them take care of themselves and let them live at home. But now they're stepping up their responsibilities. They're paying rent to live there, room and board. They're doing their laundry. They're contributing to food in the house. This is the real world. So let them do that. So this young gentleman just wasn't ready. And so he went to the community college, took liberal arts like I suggested, but then after the first term, he dropped out. Okay, and now he's doing volunteer firefighter. So, frontal lobe, decision making. Don't rush, it takes time, right? Many of us got into nutrition later on in life, it wasn't an immediate decision. So the brain is extremely, extremely important. It's constantly developing. The brain loves movement, it loves motion. Let kids play at the park. That's why kids love swings, they love seesaws. They're always moving. They like to be on skates. Even adults. Adults like to be skating. They like skiing. They like biking, anything that deals with acceleration or linear acceleration. Kids love going to amusement parks and doing roller coasters and rides because innately the brain loves that stimulation, whether it's the vestibular apparatus of the inner ear feeding the brain, which is still neurological tissue, whether it's the cerebellum constantly being challenged, for balance and fine coordination, whether it's the precentral gyrus of the frontal lobe that's trying to initiate movements, whether it's the occipital lobe that's taking in all the visual input. I mean, it's tremendous. It is tremendous. So the brain loves fat as well. It loves fat. It loves cholesterol. It's about 20%, if not more, fats. So people that are on a low-fat diet or anti-cholesterol and anti-lipidemic medications, really not good for the brain. It's probably why they develop, early signs of cognitive impairment and dementia-like symptoms. So let's take a look here and let's see if you can identify where's the front and where's the back. Let me give you a second. Take a look at that. Which is the anterior? Find the frontal lobe, find the occipital lobe. First, you got to find the cerebellum. So here's the cerebellum, which means this is posterior, which means the occipital lobe is back here where the occipital bone was, and then here's the frontal lobe. And since we're looking at it from the left side, this is the left hemisphere. More linear, language, science, that's more left brain. Right brain is more artistic, music, facial recognition, creative stuff is more right side. Left is more language and linear. So what we do for people, children especially, that have a lot of learning disabilities and speech delays, which is far greater than ever, especially boys and speech delays, we do a lot of work to try and light up that left part of the brain, which is where the speech center is. It's called Broca's area. Okay, and then there is a sulcus, very important one, called a central sulcus. It's this separation that goes right through here in this direction. And then knowing where that is really important, because then we have a gyrus in front of that called a precentral gyrus, and then there's a gyrus behind it called a postcentral, pre and post. So we have a precentral gyrus and we have a postcentral gyrus. The precentral gyrus is where all of the motor activity begins for every part of the body. And I want you to Google homunculus so you can take a good look and research what the homunculus is, or you could simply look it up in your textbook. You'll find it there. And then the postcentral gyrus also has a homunculus there, which is a representation of the entire body. And this is where all of your sensory information finally ends up. So all of your sensory data, except for the sense of smell, comes up and is relayed to the thalamus. And the thalamus has all of these different nuclei that will relay it to a specific part of the postcentral gyrus. When you look at the word homunculus and you look at the book, or if you go to Google Images and you find it there, you'll see that the parts of the body, like the lips and the fingertips and the feet and the face, are very, very large. They take up a lot of brain space. And the same thing goes for the motor side, because moving your pinky takes such precision. Moving your eyeballs just a little bit takes precision. And then the parts that are larger muscles, like the quads and the hamstrings, occupy a smaller part of the brain. Although they're larger muscles, they're more grotesque movement, right? More precision occupies more neurons in the brain. Okay, you'll see that type of pattern. Okay, let's move on. And again, just in another view, because I really want you to own this type of information, understanding from top to bottom, we can look at the different parts of the brain. We have the cerebrum. Then we move down, we have the diencephalon that has everything with thalamus, hypothalamus, epithalamus, and it also includes the pineal gland. Okay, the brainstem, moving more inferior, is the midbrain, the pons, and the medulla. And then on the posterior side is the cerebellum. There's the cerebellum. It looks like the leaf. And it really does look like a leaf, and there's a few interesting parts of it that do relate to a tree. One is called the arbor vitae, and the other is called a folia. The arbor vitae is this white matter, looks like the veins of the leaf. And then the folia, like foliage, is the gray matter, which are the folds outside of that. All right? The protective coverings of the brain, let me go back there, went too fast. We have the bones, the meninges, and cerebral spinal fluid, as well as the meninges, the dura mater, the arachnoid, and pia mater. That's from outside to in. Dura is the outermost layer, arachnoid's in the middle. It means like spider web, and the pia mater is all the way on the inside, closest to the spinal cord. But you can also see the ventricles. I'm just going to point them out here, although we will look at them in a little bit. But you could see the chambers here for the lateral ventricles 1 and lateral ventricles 2, and then the third ventricle and the fourth ventricle. Okay, and then we just have chambers, like to go from the third ventricle into the fourth ventricle, we have that cerebral aqueduct. Okay, and in every ventricle, we have a choroid plexus, which is lined with ependymal cells, and they're responsible for making cerebral spinal fluid. You can see the extensions of dura mater. All of these tissues here are just part of dura mater, whether it is the tentorium cerebelli or the falx cerebelli. These are just all other, different parts of it. Blood flow to the brain. The brain's going to occupy about 20% of the blood at any given time. But how does blood get up there? Well, we have two major routes. We have vertebral arteries, and then we have the common carotid artery. Now, the common carotid, anytime you see the word common, just like when we did the sciatic nerve, we said it's going to divide into something, right? The sciatic nerve had the common peroneal nerve, which divide into a deep peroneal and a superficial peroneal. Whenever you see the word common, whether it's in blood vessels, whether it's in nerves, it's going to divide into two things. So the common carotid is going to divide into an external carotid and an internal. It's the internal carotid that goes into the brain. The external carotid stays external. So the vertebral artery also goes through the transverse foramen of C1 through C6. Okay, doesn't go through C7, it goes C1 to C6. So if there is some sort of blockage in a vertebral artery, blood can still get up to the brain using the carotid. If there's an issue with the carotid, it can get up through the vertebral artery. Okay, and then there is a part of the circulatory system where they all come together in the brain, creating a circle called the circle of Willis. And when we get into the circulatory system, we'll get into that in a little bit more detail. And how does blood get drained from the brain and move back to the heart? That's going to be the jugular veins. There's no carotid veins. The analogous portion to the carotid would be the jugular veins. So the brain's going to utilize 20% of the body's oxygen supply. Any interruption of the oxygen supply can result in weakening, permanent damage, or death of brain cells. We know that we call them brain attacks, or they're called TIAs, transient ischemic attacks, or it's called a stroke. Glucose deficiency can produce mental confusion, dizziness, convulsions, and even unconscious. Here is the circle of Willis. Just wanted you to, let me see if I can, let's use blue. So here's the vertebral arteries, and both vertebrals come together to form the basilar. And then we have a posterior cerebral, a middle cerebral, and there's also an anterior cerebral. And the carotids are here. Here's the internal carotid cut. And there's also a posterior and anterior communicating. So here's the anterior communicating artery, and there's the posterior communicating artery. The circle of Willis is here, right? It ensures that there's a way of getting blood around to all parts of the brain, even if there seems to be an obstruction in one blood vessel on the other side. Okay? There's always another way of trying to divert blood there. Now, depending on where there could be a obstruction or hemorrhage, right? Any of these blood vessels can be blocked, creating ischemia or lack of blood flow, which can cause necrosis and dying brain cells, or one of these blood vessels ruptures or dissects. It can actually result in a stroke. And depending on which area that blood was going to, now those neurons within that area start to die and you start to get malfunction. Okay, and we know if it's on the left side of the brain, it's going to affect the right side of the body. So when people have strokes on the left side of the brain, that's when their speech becomes affected. Okay, but also they become impaired on the right half of the body. It's called hemiparesis. Okay, the blood-brain barrier, those astrocytes, remember that? They protect the brain cells from harmful substances and pathogens by serving as a selective barrier to prevent passage of many substances into the brain. The blood-brain barrier, the BBB, can prevent the entry of therapeutic drugs. So usually what they'll have to do is and they try and find creative ways, since the brain loves glucose, they'll try and drive a certain chemical or drug or pharmaceutical into the brain with sugar or high glucose. Injury to the brain can cause a breakdown of the blood-brain barrier, permitting the passage of normally restricted substances into the brain. CSF, cerebrospinal fluid, is a liquid that protects the brain and the spinal cord against chemical and physical injury, and it carries oxygen, glucose, and other important substances from the blood to nerve tissues. And this is where we have those 4 ventricles. So this is like a 3D, third-dimensional view where you can see it's deep to the brain, where we have the lateral ventricles. And then that fluid has to flow through the interventricular foramen of Monroe to get into the 3rd ventricle. And then to get in from the 3rd to the 4th ventricle, it's got to go through the cerebral aqueduct of Sylvia or the cerebral aqueduct of Sylvis to get into the 4th ventricle. And then the way it leaves the 4th ventricle is either going through the lateral aperture or the median aperture. And then it starts to go down the central canal. So it's going to bathe and circulate around the entire brain. It's going to end the spinal cord through the subarachnoid space, and it's going to soak all the way down the central canal, which is, remember, in the cross section of the spinal cord. If we make that butterfly in the middle, the central canal is right there. All right? And then it's going to go down to the sacrum, and the sacrum is going to pump it back up. So it's called a craniosacral pump. Craniosacral pump. That's why coming through the birth canal is such an important thing, because rather than C-sections, when you go through the birth canal, the vaginal opening and the diameter of the baby's head, if you do the math, it just doesn't add up. But thank goodness those fontanelles, or where those sutures are, they fold in when the baby is coming out. So the pressure compresses those sutures and all of those cranial bones, compresses them in, and then when the baby finally comes out of the vaginal canal, they expand, they puff out, and it starts this pumping mechanism. Same thing with the lungs, right? When you go through the vaginal canal coming out at birth, the chest cavity is compressed, and then when the baby comes out, it allows this full expansion, like a spring compressing or loading and then recoiling. It's almost like a butterfly coming out of a cocoon, right? If you cut the cocoon for the butterfly, it never gets the pressure of the wings. It can't really come out and fly. It's got to break through that tight exit all by itself so that those wings can fully expand. So there is some association between C-section babies and the lack of that proper CSF flow in the beginning, also maybe with some learning disabilities later on in life, as well as some asthma, bronchitis, and lung pathologies. Also keep in mind, when they don't go through the birth canal or through the vaginal, as a vaginal birth, they don't take in the bacteria in the mouth to build up the bacteria in their intestines or gut to build up a good, healthy immune system, right? And that's where good probiotics come into play. In terms of CSF, about 80 to 100 milliliters or 3 to 5 ounces that's produced. It's a clear liquid that has glucose, proteins, and ions, and it's got mechanical, chemical protection and circulation. So mechanically, it's going to float and soften. It's going to like create a little float, like kind of like a buoy sitting in water in the ocean. So it's going to float the brain and soften the impact of any type of head trauma. Chemical protection due to the ionic concentrations that are involved for action potentials, and then of course for circulation to help bring certain nutrients and waste products to and from the bloodstream. And again, here's a good look at the ventricles, and you should be familiar with the lateral ventricles, the 3rd ventricle, and the 4th ventricle, and then the interventricular foramen of Monroe, know that, and the cerebral aqueduct of Sylvis or Sylvia. The choroid plexus is a group of capillaries that are covered by ependymal cells, and those ependymal cells are going to produce the CSF. Here's just a really nice picture. On the right-hand side, bolded, you can see the ependymal cells. And you could see the really nice opening of the lateral ventricles there. You can even see the choroid plexus on the left as well. Now here's a view, a different perspective, showing the ventricles once again. So here's the lateral ventricles, 1 and 2. Here's the third ventricle, and here's the fourth ventricle. You can see the interventricular foramen of Monroe, which is how it exits the lateral ventricles 1 and 2 and gets into the third ventricle. And then we can see the cerebral aqueduct of Sylvia or Sylvis going from the third into the fourth ventricle. You can see the lateral aperture, you can see the median aperture, and you can see the central canal right there. So you can see how CSF is produced by the lateral ventricles, choroid plexus, the third ventricle choroid plexus, the fourth ventral choroid plexus. Then it's going to move from lateral ventricles through the interventricular foramen of Monroe into the third ventricle, through the cerebral aqueduct, and then into the fourth ventricle, through the lateral and medial apertures, into the subarachnoid space, into the arachnoid villi and dural venous sinus to become reabsorbed. It goes into venous blood, goes into the heart, the lungs, into the arterial blood, back into the choroid plexus, lateral ventricles, third, fourth ventricle, choroid plexus, and then that CSF is gonna move down again, lateral ventricle 1 and 2. So it's called the craniosacral flow. It's gonna pump from the top all the way down to the bottom, circulate back up. It's going to be reabsorbed through the arachnoid villi. So you can see this purple cluster of grapes here, the arachnoid villi. Here's the subarachnoid space where it flows. And this is the superior sagittal sinus, that little chamber right up there on top. We can see pia mater, arachnoid, and dura mater, which are the cranial meninges. This is the cerebral cortex. Whenever you hear cortex, you're really thinking the cerebrum, okay, the gray matter of it. Hydrocephalus is when there's a blockage of that flow of cerebral spinal fluid. So there's going to be the buildup of pressure, and then the head expands, which puts a lot of pressure on the brain. It could be due to a tumor, inflammation, some sort of developmental malformation, meningitis, and of course, some sort of head injury or even a hemorrhage. That production is the continued production of the CSF without the appropriate drainage is going to cause hydrocephalus, which is water on the brain. And then the only way to try and help that is if they release that pressure by putting a stent in, and it tries to kind of, shunt that blood away from the brain out, into the neck or into the abdomen. Okay, let's do a little overview. Again, let's review. Let's go to the cerebrum first. After the cerebrum, we'll do the diencephalon, which is the thalamus and the hypothalamus, and the epithalamus and the pituitary. Right, so it's all of this in here, all of this stuff. Brainstem, which is the midbrain, pons, medulla. There's your pituitary gland. And the posterior part, cerebellum. Ventricles are in the inside here. Okay, little reinforcement for you. All right, let's look at the brainstem and the reticular formation. The brainstem is composed of the medulla oblongata, the pons, and the midbrain. Okay, now the way they list them here is from inferior to superior. Okay, let's look at a blown up view. Right here, we can see the cerebellum, and the white part, which are the veins of the leaf, is called the arbor vitae. It means tree of life. And then the outer folds are called a folia. Here is the midbrain. There are some important structures that we'll talk about there. And with the midbrain, you'll hear me say red, black, twins in the back. Red, black, twins in the back. Red, black, twins in the back. And the red is for the red nucleus, the black is for the substantia nigra, and the twins in the back here are the corpora quadrigemina, which means body of four. there are two superior colliculi and two inferior colliculi. So red, black, and the twins in the back. Here's the pons, where you're going to have the apnoistic and pneumotaxic center that's involved in regulating respiration. And then we have the medulla. Again, in the medulla are cranial nerves 8, 9, 10, 11, 12. In the pons, 5, 6, and 7. And in the midbrain, 3 and 4. So in the medulla, which is a continuation of the spinal cord, we have tracts. And remember, we have ascending and descending tracts. The ascending tracts are sensory. Motor tracts are the descending tracts. So going up, ascending, the down elevator is descending. Every bit of information has to go through the medulla. Whether it's a sensation that you feel from stepping on something or a tack, it's got to go all the way up. All of the perception of your lower limbs have to go up through the neck. There's this what's called somatotropic distribution, where there's actually tracks for the cervical, thoracic, lumbar, and sacral representation in the medulla oblongata in a cross section. So it is very likely that when people are experiencing subluxations in their neck, or disc herniations, or nerve impingement, or spinal cord impingement from a disc, or misalignment of a vertebrae, it can actually affect the lower portions of their body easily. The nuclei of 5 cranial nerves, and we said it's cranial nerve 8, 9, 10, 11, and 12. 8 is the vestibulocochlear, 9 is the glossopharyngeal, 10 is the vagus, 11 is the spinal accessory, and 12 is the hypoglossal. The cardiovascular center and respiratory centers are found in the medulla oblongata, and this I can tell you from personal experience, from dealing with patients for over 20 years. I love to do pre and post blood pressure checks with my patients, and I use spirometry, and I can make an adjustment to their atlas, let the patient rest, and then take a post blood pressure or post spirometry. And when their blood pressure is high, it can be induced by subluxation or interference to the medulla, since that is where the cardiovascular center is located. It's going to control the force and the rate of the heartbeat, as well as the diameter of the blood vessels. So if the diameter of the blood vessels are maintained in a constricted state, blood pressure goes up. If we can get them to relax and dilate, then the blood pressure will go down. The respiratory center is also in the medulla, and we know, like for example, Christopher Reeve, when Superman had that horse accident and he broke his axis, the odontoid process severed many of those tracts. Also in the medulla, there's lots of information going in and out of the cerebellum. There's lots of communication rapidly going back and forth. In the medulla is also the reflex center for coughing, sneezing, and swallowing. I remember I actually knew a doctor who was non-stop vomiting. He couldn't help it. And when they x-rayed his neck, they actually found a bone spur up at the top, putting pressure on his medulla. Okay, in the medulla, on the ventral side, on the anterior side, there is a region there. You can see that ventral surface bulge where we have the pyramids. And the pyramids are actually where this decussation takes place. And when you look at the word decussation, it sounds like deca, which is 10. And we can see the X, the crisscross, what we can see right here. This is the crisscross of the corticospinal tracts. Corticospinal, we said, controls the extremities. They originate in the brain. So the ones that originate on the left hemisphere of the brain crisscross to the right side of the body. The ones on the right side of the brain crisscross to the left side of the body. It explains why when someone has a stroke, it affects the opposite side. Right? So the left cortex controls the right muscles. The olive, or the olivary nucleus, let's go back here. Sorry about that, folks. The olive, which is right here, this region is going to be sending neurons and input to the cerebellum. It's constantly sending in these proprioceptive signals to give precision movement. So the medulla is an extremely important area, and if there's interference or subluxation to that part of the neural system, it can impair your precision, right? Touching your finger to the nose, having neat penmanship. These are things I look at when my patients are filling out my forms. I look at penmanship because it tells me a lot about their neurology. Okay, in the medulla, we have the nucleus gracilis and nucleus cuneatus. Remember fasciculus gracilis and fasciculus cuneatus? Well, here's the nuclei where they begin. These are containing sensory information for those posterior columns. And again, 5 cranial nerves, 8 through 12. So let's start with 12, which is the hypoglossal. It's going to control the muscles of the tongue for speech and swallowing. And I'll simply just ask my patient, stick out your tongue. And I want to make sure that they can stick it out nice and straight. Or I'll have them push on their left cheek and push on their right cheek so I can see its strength. And then I simply take my finger, and while they're pushing it against their cheek, I give resistance on the patient's cheek to test the strength. When someone has a stroke and they stick out their tongue, it'll typically deviate to one side. Okay. The injury will deviate the tongue to the injured side. So if the damage is to the right, they stick out the tongue, the muscles on the left side are stronger, so it pushes it to the right. The spinal accessory, it has a cranial portion and a spinal portion. So part of the spinal accessory is going to control the skeletal muscles of the throat and part of the soft palate. And then the spinal portion is going to control the SCM and the trapezius, the sternocleidomastoid and the traps. I had a patient, I remember about 15 to 18 years ago, and I noticed right away when I saw her, she had one shoulder that was very low, and she was wearing the pocketbook with the strap on the other shoulder. Because if it went on the other one, where it had the low shoulder, it would slide right off. So it wasn't that she had a high shoulder on the opposite side, it was that she had atrophy of her left upper traps due to medulla damage. And that cranial nerve 11 was majorly affected because she actually fractured C1 through C4. Okay, so she had a plate in her neck. She could hardly move her neck. It was a major, major accident. They had to land a helicopter for her and, put her in a halo, to keep her head still. I mean, it was major, major accident. Cranial nerve 10 is the vagal nerve. It's called vagus because it controls the heart, all the smooth muscle of the viscera. It's going to control digestion, control all the digestive fluids, and it's involved in controlling about 90% of the parasympathetics. This is why I love, love, love being a doctor of chiropractic, and this is why I incorporate chiropractic and nutrition together, because when you look at that vagal nerve and you look at what it controls, it's very hard to give nutritional advice and suggestions if part of their malabsorption is coming from the inability of the vagal nerve to communicate to every digestive organ to allow it to function. Okay, it's highly sensory, that vagal nerve, highly, highly sensory. It's picking up so much information. It's even the pathway for which the cytokines that the bacteria produce in the intestines find its way up to the brain. It's a highway of communication. It's why probiotics can affect someone's mood. It's why what you eat can make you feel happy or make you feel sad, right? It's because of the vagal nerve communication of that bacteria, bringing it up and feeding that to the brain, right, into the medulla oblongata. That vagal nerve, extremely important. So by making an adjustment to C1 or C2 has a major impact to that part of the brain. And there's nothing like the input of that type of stimulus that lights up the brain. There are so many incredible studies that are done on using that to light up the brain, and especially there's so much of the adjustment input from an afferent standpoint, it lights up the frontal lobe like nothing. But we can also light up different parts of the brain, but the majority of it ends up in that frontal part of the brain. Okay, so vagal nerve is very important. You can look that up. You'll see lots of research with blood pressure there. You'll see lots of research with today in the area of psychology and depression, where they use these vagal nerve stimulators to try and treat it. Well, doctors of chiropractic have been doing that since 1895, folks. In fact, back in the early 1900s, there was a sanitarium called a Clearview Sanitarium, which was an institution where they only treated depression, bipolar, schizophrenia, and they did it without drugs. And it was doctors of chiropractic and psychologists and psychiatrists that helped to write up these cases and write up the research. But it's there. It's called a Clearview Sanitarium. Glossopharyngeal, which is cranial nerve 9, it deals with bitter, the taste of bitter, to the posterior 1/3 of the tongue. So then you may ask, well, what does the other 2/3 of the tongue? That's cranial nerve 7. 7 does sweet, sour, and salty 7. Sweet, sour, salty 7, but bitter back 9. Sweet, sour, salty to the anterior 2/3 of the tongue is cranial nerve 7, which is the facial nerve, whereas cranial nerve 9, the glossopharyngeal, does the sense of bitter to the posterior 1/3 of the tongue. It also deals with secretions to the parotid gland, okay, and it deals with the stylopharyngeal muscle, which helps to lift the throat during swallowing. Vestibulocochlear. This is an interesting cranial nerve. It is actually involved to the history of my first profession as a doctor of chiropractic, because the first patient was deaf whose hearing was restored. His name was Harvey Lillard. And when you look at vestibulocochlear, it is the cochlear portion that deals with hearing. And it's the cochlear portion that begins in the medulla. The vestibular portion of this cranial nerve actually begins in one level above, which is the pons. Okay, so the hearing portion begins here in the medulla, but the vestibular portion begins in the pons. But vestibulocochlear is balance and hearing. We know that the inner ear has the vestibular apparatus, and it is a really amazing structure. Just last week alone, I had to treat 2 patients with BPPV, which is benign paroxysmal positional vertigo. And BPPV, I'm sure you can relate to it either from personal experience, which may be rare, but certainly may have heard of someone, a family member or friend, that tells you they have vertigo and dizziness and they feel really off, but it's only during certain positions, right? Like when they lean their head back, everything spins, or when they turn in bed to the right, oh my God, it feels like they're falling in space, or leaning their head forward throws them for a loop. So this is the vestibular apparatus in the ear, and rather than using motion sickness medication, I have a really good track record of fixing this in 3 minutes or less. And patients typically cry in the office from happiness because they've been suffering and suffering and suffering for years and years. And in 3 minutes, we've had them fixed from really working with the vestibular apparatus of the inner ear and getting those crystals back where they belong, to the right place. It's kind of like, when you were a little kid, sometimes if you've gone or you won this prize, it looks like a little puzzle. Not a puzzle, like a little maze, one of those plastic mazes that has that little silver BB or that little silver ball, and you have to maneuver the ball to get it in the hole or move it through that maze. That's how I end up treating the patients, depending on where that crystal is. If it's in a posterior canal, then we know we have to move the head in a very specific way to get those crystals out of the canals, because the crystal hitting the vestibular canal, those little hairs, is signaling movement. And you can see the eyes actually flipping back and forth in what's called an nystagmus. So in any way, in chiropractic, Harvey Lillard was deaf, and when the adjustment was made, Harvey Lillard's hearing was restored, and that was how the profession of chiropractic began in September 18th of 1895. So the cochlea is the receptors for hearing, and then the vestibular apparatus deals with the sense of balance. So vertigo can come from the feeling of rotation, can come from the vestibular branch, and ataxia is when your balance is off and people are walking with this wide-based gait, like when someone's drunk, they've had too much alcohol, they can't walk with their feet close together, so they walk with the feet apart. That's called an ataxic gait. It's the lack of coordination. Here's a really, really good look. And let me show you the vestibulocochlear nerve. So here is the vestibular branch of cranial nerve 8. You can see it's Roman numeral. And then here is the cochlear branch of cranial nerve 8. So this section here has the organ of Corti in it for hearing. And then here's the vestibular apparatus. It's called semicircular canals. There's fluid in there. And there are crystals that are supposed to hang out in these dilated sections. But when they move and they get stuck here, or they get stuck here, or they get stuck here, it's this constant bombardment of depolarization that takes place there. And they constantly feel like they're moving. Okay? Here is the tympanic membrane. Let me change the color here. Let's make it black. So here is the tympanic membrane. So when sound waves come in, they vibrate that tympanic membrane, and that vibration moves through the bones. The malleus, the incus, and then the stapes. And that vibration starts to create this oscillation back and forth, this like pulling, pushing sensation. And it tends to create a vibration through this fluid going through the organ of Corti, and that vibration will send a specific frequency through the cochlear nerve, and then the cochlear nerve will end up sending its signals into the brain for hearing. And it will go to different parts of the brain to allow the interpretation of what you're hearing. Is it a word? Is it a sound? It helps you interpret the intent to what's being said through using tone. All right, so here's the pons. You can see the green section above. There's the pneumotaxic and apnoistic area that also help to control the breathing. And there's a section in there called the cerebellar peduncles that are just carrying sensory info to the cerebellum. The cerebellum is constantly being bombarded with information because it deals with balance and fine coordination. Cranial nerves 5 through 7 are there. So let's take a look at these cranial nerves. The trigeminal nerve, abducens nerve, vestibular nerve, facial nerve, and the vestibular portion of the vestibulocochlear nerve. So let's look at the facial nerve, cranial nerve 7 first. There's sensory and motor function. The facial nerve controls the muscles of facial expression, like the frontalis muscle, raising the eyebrows, frowning, whistling, blowing out your cheeks, puffing up for a kiss, right? These are all facial muscles. It also deals with the salivary glands, but not the parotid. Parotid is cranial nerve 9. It deals with the salivary glands. So the pons is extremely important to initiate digestion, isn't it? It's involved in the nasal and the oral mucus glands and tears, lacrimation. So the sensory part deals with the senses of sweet, sour, and salty to the anterior 2/3 of the tongue. When the facial nerve becomes damaged on half the side of the body, the face can droop. They call it Bell's palsy. The facial nerve is involved in the eye, and let me draw an eye here so we can always remember this. So let's say here's an eye. We have a few cranial nerves involved with the eye. So let me draw this. Let's say 1, 2, 3. Cranial nerve 3, it looks like 3 columns, like 3 Greek columns. Cranial nerve 3 is designed to keep the eye open, whereas cranial nerve 7, I'll make it like this, like with a hook. Cranial nerve 7, I'm making the number 7 with a hook. Think of the hook grabbing onto the eyelid and pulling it shut. So cranial nerve 7 closes the eye. Cranial nerve 3 is designed to keep it open. And then cranial nerve 5 deals with sensation to the eye. So if you are outside or biking and dust gets in your eye or a little bug hits the eye, the sensory part of cranial nerve 5 detects that something touched the eye. And then cranial nerve 7 will shut it. Okay, so that's part of the blinking reflex. Cranial nerve 3 keeps it open. Okay, good information there for you. Abducens. All right, let me draw this out. This is kind of important too. So let's say here's an eye, here's the nose, and let's do the other eye. Okay, now we can test the eyes in different directions. Okay, so if I ask the patient to follow my finger and to look this way with this eye, so let's say this is their left eye and this is their right eye, right? Because in anatomical position, they're looking at us. So if they look this way, I'm testing the lateral rectus muscle. With this eye, once again, if I have them look in this way, I'm testing the integrity of the medial rectus muscle. If I have them look up and out, following my finger in this direction, then I'm checking the superior rectus. And if I have them look down and out with this eye, then I'm checking the inferior rectus. Okay, now there's 2 muscles left. Let me change the color for that. Let's make it blue. It's moving the eye up and in or looking down and in. And remember, they're going to be covering this eye. So I'm testing this eye first. This one, oddly enough, tests the integrity of the inferior oblique, whereas looking down and in tests the integrity of the superior oblique. Now, in terms of these muscles, there are cranial nerves that control these. So I'm going to give you Lindner's chemical equation, which is SO4 LR6 all over 3. Okay, so Lindner's chemical equation is SO4 LR6 all over 3. What does this mean? This means that the superior oblique muscle is controlled by the 4th cranial nerve, that the lateral rectus is controlled by the 6th cranial nerve, and all over 3 means all the other eye muscles are controlled by cranial nerve 3, the oculomotor. So the superior oblique is controlled by the trochlear nerve. The lateral rectus is controlled by cranial nerve 6, which is the abducens nerve. And if you look at abducens, it means abduct. And which way is the eye moving? For the lateral rectus, it's moving away from midline. It's moving away from the nose. That's abduction. Okay, good information there. Trigeminal nerve. Trigeminal is really important. It's a cranial nerve that I use in the office to help treat migraine headaches because there's a little instrument that I use that delivers a mild electrical current into the body, tapping in to this part of the brain to ease migraine headaches, and it works pretty much instantaneously. Remember, the trigeminal nerve has 3 branches. Okay, it has an ophthalmic branch, which goes to the eye, and that's typically referred to as VIII. V1. There's a maxillary branch going to the upper jaw, which is V2. And then there's a mandibular branch going to the lower jaw called V3. And again, the V is for cranial nerve 5. So there's 3 branches, and because there's 3 branches, it's called trigeminal. But it deals with, from a sensory perspective, touch, pain, and temperature receptors to the face. So some people really say they have a headache and it's right behind the eye, or it's like it feels like it's just above the eye, or it feels like it's on the entire side of the face near the temporal lobe. Okay, that tells me it's trigeminal, so we can work with them. The muscles of mastication, these are the muscles of chewing. I call them time muscles. T-I-M-E. The T is for temporalis, the M is for the masseter. We know that these are muscles of mastication. The I and the E are for the pterygoids, but there's an internal, that's the I, an internal pterygoid, and an external pterygoid for chewing. So you see the trigeminal nerve is really important when it comes to nutrition, because if you can't break down the food with your teeth from chewing, how are you going to properly digest it? Right? It starts in the mouth with mechanical digestion and, of course, a little bit of chemical digestion. So not only is cranial nerve 5 involved, but how about the tongue to manipulate the food in the mouth? And how about the tongue to taste it? So you have cranial nerve 7 for sweet, sour, and salty. You have cranial nerve 9 for bitter. You have cranial nerve 12 for movement. You have cranial nerve 5 to taste, not to taste, but to determine the temperature, because it's pain and temperature to the tongue. When you bite your tongue and it hurts, it's the trigeminal, the V3 that picked that up. Okay, so so many different cranial nerves are involved with digestion. You have cranial nerve 7 because of facial recognition. How do we know whether you like the food or dislike it? Facial recognition or facial expression tells us, but you need to manipulate the food with your lips, right? So cranial nerve 7 for the lips. Cranial nerve 12 for the tongue. 5 for pain. 7 and 9. 7 for sweet, sour, salty. 9, bitter back 9, and plus the parotid gland. Right? So many cranial nerves are involved with digestion. And cranial nerve 1, olfaction, to smell the food, right? The intelligence that created the body put the nose above the mouth so we can smell the food before we eat it, right? When people say, oh, don't be rude, don't smell your food, that's rude. It's like, what, are you kidding me? It's above the mouth. I want to know if my body's going to agree with it, and that first olfactory nerve is going to tell me, yeah, or it's going to go, And usually the when it hits the mouth, usually would make the individual gag as well. Okay, really good look at the trigeminal nerve here. Again, you can see we have V1, the ophthalmic branch. We could see V2, the maxillary branch, and then V3, the mandibular branch. Okay. I remember being at the dentist that just opened up in my town many years ago. I just said hello, and she checked my teeth, and I actually had a cavity, and she did me a solid. And when she injected me, she came in with the Novocaine and actually hit that nerve. And what did I experience? Incredible shooting pain down my face. Shooting pain. It's called trigeminal neuralgia, also known as tic douloureux. People that have tic douloureux, the wind can blow and hit their face, and it creates that shooting lightning pain to their face. It's actually it is the most painful neurological condition that exists. It's considered suicidal pain. Neuralgia, it's called tic douloureux or trigeminal neuralgia. It's lightning shooting pain to the face. It is fixable. Now, sometimes it's from a virus that sits here in the nerve, and in other individuals, it's because they have a blood vessel that's a little bit close to here, and when it dilates, they get this shooting pain to their face. Okay, let's look at the midbrain. The midbrain is located superior to the medulla oblongata, and it extends from the pons to the diencephalon. So it's about 1 inch long, and let's see if we can box it out. There it is, right there. And I want you to remember red, black, twins in the back. Red, black, twins in the back. All right, I'm going to show you the red is for the red nuclei. Black is the black substance, substantia nigra, and the twins in the back, corpora quadrigemina. It's going to convey motor impulses from the cerebrum to the cerebellum and the spinal cord. It's going to send sensory impulses from the spinal cord to the thalamus, and it's involved in regulating auditory and visual reflexes, especially the twins in the back, the corpora quadrigemina, where we have superior and inferior colliculi. Okay, it's also known as the tectum. So the substantia nigra is going to help control subconscious muscle activity. This is the area that is responsible for producing and releasing dopamine. And when there's a dopamine deficiency, we call this Parkinson's disease. Parkinson's disease is when they have the lack of motor control. They have difficulty in initiating walking. So they have what's called this festinating gait, where the patient kind of leans forward and they take these very fast, short, rapid steps, but they have to lean forward to kind of throw their balance off to create this momentum to initiate forward movement. They have this mask-like look expression on their face. If you remember Muhammad Ali, he had this mask-like look of expression on his face, and very, very tight, stiff muscles. The red nucleus is rich. It's red because it's rich in blood supply, but it also has an iron-containing pigment. And that's why antioxidants are so important, because if someone has a lot of oxidation going on in their body and you get rust buildup in the midbrain, it can lead to a lot of neurological complications. The red nucleus is very important in relationship to the cortex and the cerebellum, coordinating muscular movements by sending information into the red nucleus and then from the cortex and the cerebellum. So it's going cortex and cerebellum coordinating muscle movements by sending information from the cortex and the cerebellum to the red nucleus. Okay, I'm going to highlight the corpora quadrigemina in just a second. There they are. So it's called the body of four, or corpora quadrigemina, because there are two superior colliculus, one here, and two inferior colliculus, here and here. So it's called a corpora quadrigemina, the body of four, the superior and inferior colliculi. The superior colliculi is involved with visual stimulus, and the inferior colliculi deals with auditory stimulus. So when you hear a loud bang to your right and your head moves in that direction, that is coordinating head movement based on what you're hearing. Coordinating eye movement, having the eyes move rapidly like in a saccade, a very fast, rapid movement in either direction, or simply tracking as you're reading a book and having your eyes track, that's the superior colliculus. Okay. Medial geniculate nucleus and lateral geniculate nucleus, here and here. The medial geniculate deals with hearing, and the lateral geniculate deals with sight, with seeing. Okay, 3 and 4. So trochlea, remember, LR6 or SO4, LR6 all over 3. So SO4 is the superior oblique muscle, trochlear nerve. That's going to move the eye if I'm covering an eye, and I can have them follow the eye down and in. That is the superior oblique muscle. The oculomotor, cranial nerve 3, we said when I drew out the eye, the 3 Greek columns keeping the eye open. If it's not working, then the eye droops, and that's called ptosis, P-T-O-S-I-S. It's involved in raising the levator palpebrae. Otherwise, you get drooping of the eye, called ptosis. There are 4 extrinsic eye muscles and 2 intrinsic eye muscles. So cranial nerve 3 deals with all the other eye muscles except for SO4 and LR6. So anything other than the superior oblique and the lateral rectus is going to be cranial nerve 3 from a motor perspective. There are two intrinsic eye muscles that are involved in accommodation for near vision. It changes the shape of the lens, and it's involved in constricting the pupil. So when I shine light in the right eye, cranial nerve 2 senses the light, but cranial nerve 3 is actually going to constrict it from a motor perspective. And that's called the direct light reflex. So if I cover the left eye and I shine light into the right eye, the right pupil should constrict. However, I can shine light in the right eye and look at the left eye, and that one should also constrict as long as there's communication between those two nerves, and there really should be. Okay, the reticular formation helps to regulate muscle tone. It alerts the brain to incoming sensory signals. It helps you stay awake during this lecture. Okay, when I see students in class and their head starts to tilt and they're falling asleep, and then they correct themselves by sitting up erect very quickly, that's part of the reticular formation. When you're in your home and you smell smoke and you can get up, that's the reticular formation at work. When you hear a burglar in your home and you can get up, that's the reticular formation. When those can sleep through an earthquake, right? We all know some of those. The reticular formation needs a little bit of a tune-up, I think, okay? Okay, so there's just taking a good look at the cranial nerves going to the eye. We can see if we can highlight these. You can see the trochlear nerve. We can see the optic nerve. We can see the oculomotor nerve. We can see cranial nerve 5 for sensation. That's the trigeminal nerve. Okay. We can see cranial nerve 7, which helps to shut the eye. And then we can see the lateral rectus, the medial rectus, the inferior rectus, the inferior oblique, the superior oblique, and levator palpebrae. Okay, so the reticular formation is a bunch of just scattered nuclei throughout the medulla, the pons, and the midbrain. And it alerts the cortex to sensory signals like sound, an alarm, flashlight, smoke, an intruder. It helps to wake you from a sleep. It maintains consciousness as well. It helps to keep you awake with stimulus from the ears, the eyes, the skin, and the muscles. The motor function, it's involved with maintaining muscle tone. Okay, so here's a good review of the medulla, the pons, and the midbrain. Let's look at the cerebellum. Pretty straightforward. The posterior part, we see it's posterior to what? It's posterior to the midbrain, the pons, and the medulla. And here is the fourth ventricle. A few important landmarks. The vermis, right here in the center, looks like the worm. And then you have two cerebellar hemispheres, one here, one here. Not cerebral hemispheres, cerebellar hemispheres. Okay. There's a posterior lobe, there's an anterior lobe, there's a flocculonodular lobe that's just in front of the worm or the vermis. We have folia, it's all gray matter. And then we can see these peduncles, the superior, middle, and inferior peduncles. So the cerebellum occupies the inferior and the posterior part of the cranial cavity and has two hemispheres and a central vermis. Okay. The functions, it's to correct voluntary muscle contraction and posture based on all the sensory input that's coming from the rest of the body about what's actually happening. So it's about precision, right? A sobriety test, taking your finger and touching it to the tip of the nose with your eyes closed. That's cerebellar function. Walking heel to toe is cerebellum, being able to coordinate that, but being able to maintain balance as well. Gives you that sense of equilibrium. So when I have someone stand and then they close their eyes and they spill and they lean to the left, there's an imbalance to the left cerebellum. If I have them stand with their eyes closed and I have them walk and take high steps and they start drifting to one side, it's a cerebellum imbalance. So the cerebellum functions to coordinate the skeletal muscle contraction, maintain muscle tone, posture, and balance. You can look here in this picture. I really like this one because you can see clearly the arbor vitae, the white matter, and the folia, which is a gray matter. Another great picture, just the different colors showing the arbor vitae, which is white matter, and then the folia, which is gray matter. Arbor vitae, what do you do on Arbor Day? You plant a tree. So it's tree of life. The diencephalon is composed of the thalamus and the hypothalamus and the epithalamus. And let's see if we can show you that one. So here's the thalamus, and below it is the hypothalamus. And there's so many different nuclei. Thalamus, which is sensory, except for the sense of smell. And hypothalamus is going to control just about everything in the body through the autonomics, sympathetic and parasympathetic. It kind of oversees that. So here's the thalamus, and it's going to relay, as it receives all of the sensory input, it's going to relay to the post-central gyrus, right? Here's the pre-central for motor. Here's the post-central, right? There's the central sulcus. These are all so many different nuclei. The thalamus, I'm not going to hold you responsible for them, but just wanted you to see how many different centers there are within the thalamus. Some are for sensory for hearing, some are sensory for hearing, some for sight. So the thalamus is located superior to the midbrain. It contains nuclei that serve as the relay station for all sensory input, except the sense of smell, and then it's going to relay it up to the post-central gyrus. There it is. From this view, you can see the thalamus here. It looks like that kidney bean structure. Now, the hypothalamus is found inferior to the thalamus and has 4 major regions, but controls many body activities, and it's the major regulator of homeostasis due to ANS regulation, sympathetic and parasympathetic. So it controls and integrates the activities of the ANS, which regulates smooth muscle, cardiac muscle, and glands. It's going to synthesize regulatory hormones of the anterior pituitary as well as the posterior pituitary. It's involved in regulating rage, aggression, pain, pleasure, arousal. It tells you when you're hungry, when you're thirsty, when you're full. And so a lot of eating disorders take place because of lesions to the hypothalamus, or an imbalance or a problem with the network of communication to the hypothalamus. These are documentaries that you see of the 1,000-pound man or the 1-ton woman. It's not that they love eating Twinkies and Oreos, is that the hypothalamus never gets the feeling that they're full. So they're constantly eating and eating and eating, hoping that they get the feeling of full. Most people, when their hypothalamus is functioning, they eat and then they wait a little bit and then they go, oh, I can't even think about food. I'm stuffed. Right? That's a good, healthy hypothalamus. It also regulates the control of temperature, so a lot of fevers are induced and created stemming from the hypothalamus, and it regulates daily patterns of sleep. The epithalamus, which is where the pineal gland is, or pineal gland, that's an endocrine gland, but it also is tied to the neural system, and it's involved in secreting melatonin, not melanin, melatonin, which tones you down at night to sleep. Melatonin is a great neurotransmitter, has a lot of benefits not only in sleeping, but it's used now to treat a lot of the symptoms of irritable bowel syndrome or IBS. So it helps to promote sleepiness and it sets your biological clock. The habenular nuclei, which is found in the epithalamus, gives you an emotional response to odors. Okay, that cooking smells good, or I don't think I'm going to like that, or that perfume smells nice, or cologne smells nice. Okay, so you can pause and just review thalamus and hypothalamus and epithalamus function if you'd like. All right, let's look at the cerebrum. The cerebral cortex, as the outer part, that's the gray matter. We have some important fissures. There's a longitudinal fissure, which is in alignment with the sagittal suture. So that's going to separate the brain into left and right hemisphere. Then there's the corpus callosum, which actually connects the left and right hemisphere together. It's involved in left and right hemisphere communicating with each other so they function better. And the corpus callosum is much, much better developed in females than it is in males. So I think women are much, much better at multitasking. Each hemisphere is divided into 4 lobes. There's a frontal lobe, a parietal lobe, an occipital lobe, and of course a temporal lobe. Let's take a look at some of these fissures here. I'm going to light them up for you in a second. So right there is the longitudinal fissure, and right here is the central sulcus. And we can see the central sulcus from this view, and we can also see it on the bottom right here. And why is that central sulcus important? Because it's going to separate the precentral gyrus from the postcentral gyrus. Precentral gyrus is motor, motor, motor. Postcentral gyrus is sensory, sensory, sensory. Again, great picture showing the central sulcus right there in the middle, the dark pink as the precentral gyrus, the purple as postcentral gyrus. The postcentral gyrus is part of the parietal lobe, whereas the precentral gyrus is part of the frontal lobe. You could see the temporal lobe, that's that peach color. Occipital lobe is green. And each of these have different centers. They're going to control different things. And again, you can see the occipital lobe and the pons and the medulla. The midbrain is higher up and it's being blocked. The corpus callosum, we can see those projections going from the left to right hemisphere. We can see that right here. Here's the longitudinal fissure. And the corpus callosum is pretty important there. So there are specific functions of the cerebral cortex, sensory, motor, and there are also association areas. Let's take a look at the organization here. The primary motor area, precentral gyrus. Here's the primary somatosensory area. So postcentral gyrus, precentral gyrus. Frontal lobe for frontal eye fields, helping move the eye. Premotor, hey, before it moves, you gotta initiate it. Prefrontal, you gotta think about moving it. Gustatory for taste. Broca's for speech. Olfactory for smell. Auditory, primary auditory. Common integration. Primary visual area. Association. So primary visual, like when the optic nerves pick up the information, it's going to send it here. And then the association area is going to interpret that, what it is you see. So you may see me 10 years from now, and you may go, I see someone. But going, oh, the association area, oh yeah, he was the very best professor I ever had in my entire life, right? Well, that's my hopes, at least, that you do think that. That's my intent. Okay. Let's get out of here. Let's get back. Basal ganglia. When I think of the basal ganglia, here I'm thinking of controlling large automatic movements of skeletal muscle. It's like when you're walking, your arm should swing naturally. If you slip and fall and move, I mean, anything that it's just unconscious. It's movement of skeletal muscles, but you're not thinking about it. It happens automatically. Limbic system has some important landmarks like the hippocampus, especially the hippocampus is important, the parahippocampus, the cingulate gyrus. You don't have to label and be able to identify all of these landmarks. I just really want you to know that the limbic system is part of the emotional brain. It perceives intense pleasure, it perceives intense pain, and when there's imbalances here, this is what gives people very, very high pain threshold or low pain threshold. You've heard of S&M, sadism and masochism. You know, for some people, a spank in the tush makes them cry, and for another one, to another individual, a spank in the tush is, "Thank you, may I have another, please?" Right? The stronger the emotion, the stronger the memory. So if you think about movies that you've seen, for example, the movies that are the funniest you tend to remember, and the movies that are the saddest you also tend to remember. So the stronger the memory, the stronger the stronger the emotion that's attached to that experience, the stronger the memory is. Okay. Okay. These are important concept here, these numbers. Each number is controlling a different function. So if we look at the primary sensory area is number 1, 2, and 3. So you can see 1, 2, and 3, which is the post-central gyrus. We look at number 17 back here, that's the primary visual area in the occipital lobe. When we look at the temporal lobe at 41 and 42, that's the primary hearing area, auditory. And for taste, number 43, right in here. Again, I just like this because I like the different colors, isolating the different parts of the brain. I'll pause that just so you could take a look at them. Okay, now on the motor side, we have the primary motor area or precentral gyrus, which is here, number 4. And then we have Broca's area, primarily found in the left hemisphere of the brain. That is number 44. This allows you to create speech. Okay, now we have these association areas. Now, these are not the primary areas, but after the primary areas receive their information, so after number 1, 2, and 3 receive the sensory, it's going to relay it to number 5 and 7 back here. So you can integrate that information, interpret and understand exactly what it is you just experienced. After number 17 sees the object, 18 and 19 allow you to recognize it and evaluate it. That's here. You understand how it works? The auditory association area is right here, number 22. So it's going to allow you not just to hear sound, but it's going to be able for you to understand what the words actually mean, and it's going to allow you to create meaningful speech, right? Sometimes we've seen people on either Home Shopping Network or the news, and these broadcasters are actually stroking out on the air, and they start babbling words that absolutely make no sense at all, okay? That's a dysfunction to that area. The Gnostic area. Well, what does Gnostic means? It means to know. So 5, 7, 39, and 40 integrate all the senses and allow you to respond. The premotor area is number 6. We see that right here. It allows you to learn skilled movements such as typing. And then the frontal eye field is number 8. It allows you to scan anything that you're reading. Okay, that's the frontal eye field is right here. Okay, it's in the frontal lobe. Okay, aphasia. We're talking about speaking now. So language areas are located in the left cerebral hemisphere for most people. They do testing for this, of course, to ensure that that's the case. The inability to use or to comprehend words is called aphasia. There's non-fluent aphasia, which is the inability to properly form words, right? You know exactly what you want to say, but you just can't say it. That's usually damage to the Broca's speech area. There's fluent aphasia, which is the faulty understanding of the spoken word. Then, in terms of word deafness and word blindness, this is now a faulty understanding of what's written or what's said. So word deafness is the inability to understand what someone says, and word blindness is the inability to understand what you just read. And damage to the common integrative area or the word association area is linked with all of these, okay? Left hemisphere and right hemisphere. When we look at the left hemisphere, we're dealing with spoken and written language, numbers, science, the ability to understand language, sign language, all left brain, and the ability to reason. Right is more spatial perception, awareness, music, being an artist, very highly wired in babies and young kids because they have to be able to recognize faces and the emotional content of facial expressions. Generating emotional content of language, right? Being able to use tones so that a person is not always talking like this, like a robot, but when they speak, they can use different tones. Okay, that's a healthy right brain when someone can do that. Generating mental images, right? So when you want to redo your home and a contractor is talking to you, oh, we can put this there. Can you see we can visualize this here? We can paint this green, do that all blue. And some people like, I just can't see it. Or people that don't coordinate their clothes very well, right? Poor color coordination. These are brain imbalances. We know females have a larger connection between the two sides of the brain, and if there's damage to the left side of the brain, then that's going to cause aphasia. Damage to the same area, but on the right side, produces speech with little emotional inflection. They just speak like this without changing their tone. Okay, and most people, the left brain is the dominant hemisphere, reading, writing, math, decision making, speech, and language, and the right side relates to senses, touch, smell, sight, taste, feel, and the recognition of voices and faces. I really like this picture for a few reasons because it clearly shows how the right side of the brain controls the left hand and the left side of the brain controls the right hand. But the other thing that I really, really love about this picture is if you look at the eye here, you'll see that if you're looking at something or something's coming in from the temporal field of view out here, right, it comes in and hits the receptors on the inside of the eye. And the information as it hits the inside of the eye crosses over to the opposite occipital lobe, right? So I used blue there. But now I'm going to change this to red, so the information that you see on the nasal field of view, that crosses over to the receptors on the outside of the eye and goes to this side of the brain, right? So nasal field information crosses over to the opposite side. You can see in this case, sorry, it crossed over to the opposite side of the eye, but stayed on the same side of the brain. The temporal field of view, that vision, that stimulus also crossed over to the opposite side of the eye, but that crossed over to the opposite side of the brain. Okay, so you can see at the optic chiasm some information like the nasal field of view is going to stay on the same side of the brain, but the temporal field of view is going to cross over. Okay, and here's a nice thick corpus callosum on the inside. In terms of brain waves, remember EMG is electromyography for muscles, EKG, electrocardiogram or ECG is for heart, and the EEG is the electroencephalogram, which measures brain waves. We want to see alpha waves in a normal resting adult. When you're taking one of my exams, you probably see beta waves for intense concentration. Hopefully, when you're taking one of my exams, we don't see many theta waves because that means that you're frustrated. And if we see lots of delta waves, then there's some sort of pathology that's going on. Okay, then alpha, beta, theta, and delta waves once again. Alpha waves are seen in a normal resting awake adult. Beta waves with intense mental focus. Theta waves, emotional stress. And delta waves in deep sleep. Olfactory nerve, optic nerve. Olfactory, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, spinal accessory, and hypoglossal. So what's the silly mnemonic to remember these 12 in order? On, let's just say O, to touch and feel very good velvet. Ah. Again, O, to touch and feel very good velvet. Ah. That's how you remember the 12 cranial nerves. Again, olfactory extends, deals with the sense of smell, right? This is now going to originate in the cerebrum. Now we're in the highest part of the brain. So cerebrum, sense of smell, olfactory nerve. And this is why you have to be very careful with your hands. You want to make sure that they're cleaned well, because if you have some bacteria or virus that comes into this membrane, you've got these olfactory nerve fibers that'll shoot it right through the cribriform plate into the olfactory nerve, and now it spreads into the brain. Okay, there's really not much space between the nose and the brain, just very little thin bone here, okay? Here's the optic nerve, and the optic nerve is going to control vision. You see that we have rods and cones here in the back of the eye. The cones are color receptors, the rods are for black and white, and notice they sit in epithelium. So we want to make sure that these are tight junctions. We don't want these leaky, otherwise you get things like macular degeneration, and we get a lot of visual problems. Oh, I love this picture. This is so nice because it clearly shows how if I have visual input on the temporal field, we know that that information is going to cross and hit the receptors on the inside of the eye. Now, when you follow this green pathway and we follow it, we see at the optic chiasm, it crosses over. Here is the relay, there's the thalamus, and then it goes to the opposite side of the brain. But if we look at information here on the nasal field of view, when they look at something that's right in front of them, that too crosses over to the receptors on the lateral part of the eye. But look where this tract goes. This one stays on the same side of the brain. The two synapses in the thalamus, but it's going to stay on the same side of the brain. So it helps to explain that why when we have pituitary tumors, if this pituitary enlarges and it pushes up against one of these specific tracts, it helps you understand whether they're going to have visual impairments on seeing things on the outside of the eye or the inside of the eye. Okay? And sometimes it's the outside of both eyes or the inside of both eyes, or the right side of both eyes, or the left side of both eyes, or a complete blindness of one eye completely. But where the optic tracts crisscross is called a chiasm. Okay, that's the optic nerve, cranial nerve 2 for vision. Let's take a look. The corneal reflex. I think I mentioned it as the blink reflex, but that's the corneal reflex. It's cranial nerve 5 and 7. 5 is sensory. That's if the bug touches the eye. 7 is going to make the eye blink. Let's see, the direct light reflex and the indirect light reflex. They're both optic nerve for sensory for both. And then constriction of the pupil is both cranial nerve number 3. Auditory reflex. For hearing, we know sensory is cranial nerve 8. And the vestibulocochlear reflex also involves cranial nerve 8. But it also, for the vestibulocochlear, it's cranial nerve 3, cranial nerve 4, and cranial nerve 6 for motor, which are the 3 cranial nerves that move the eye. Because if you tilt your head left like you're on the phone while you're walking, your eyes have to kind of rotate in the other direction. When your head looks down and you want to walk, your eyes have to go up. It's kind of like the doll reflex, those dolls, right? When you put the doll, lie it down, the eyes move down. When you tilt it back, when you tilt the head back, the eyes go down. When you tilt the head down, the eyes go up. If you tilt your head left, your eyes go right. If you tilt your head right, the eyes go left. That's the vestibulocochlear reflex. And the auditory reflex is when you hear a loud noise and then you have to move. Right, not only your eyes, but also your neck and your head have to move with it. Okay. Then there's a lot of other efferents or motor nerves involved, but 3, 4, and 6 is definitely for eye movement. But then you have 7 for facial recognition, and then 10, there's involvement of also increasing the heart rate when you hear a loud sound. We have just a multitude of things happening at one time, right? The eyes move, the head moves based on sound. This just shows how cranial nerve 3, remember SO4, LR6 all over 3. So this one here shows the lateral rectus on the bottom. This is LR6. This is SO4. And then all over 3 are all the other ones here on the top. Cranial nerve 4, same thing. It's dealing with the superior oblique muscle, which moves the eye down and in. Trigeminal, once again, we have those 3 divisions, V1, V2, and V3. There's sensory and motor. Sensory is to these 3 parts of the face, and motor, remember the thigh muscles, temporalis, internal pterygoid, masseter, and external pterygoid. Abducens, lateral rectus. Facial nerve, sweet, sour, salty, 7. Salivary glands, and facial expression. So the frontalis muscle, temporalis, occipitalis, all the muscles of the lips, cranial nerve 7. Vestibulocochlear, we're dealing with hearing and balance and equilibrium. Glossopharyngeal, cranial nerve 9, bitterback 9. Helps with the swallowing reflex. It deals with the gag reflex and deals with the parotid gland. Cranial nerve 10, right? Vagal, it's vagrant, controls everything. My favorite nerve, I explained to you why, because C1 and C2, when I make an adjustment there, when they're subluxated, can affect all of these organs. Accessory, the spinal accessory, SEM, and the upper trapezius. Hypoglossal is going to move the tongue. Developmentally, we covered this a little bit earlier, but the neural system begins at around the 18th day, around the 3rd week. It's derived from ectoderm. It forms the thickening of the neural plate, and then we start to get this folding of the neural plate to the neural folds till we get the neural tube. The notochord starts to form, and this is why folic acid is so important, and making sure that the individual doesn't have any SNPs like MTHFR, methylene tetrahydrofolate reductase, if they don't have that enzyme, then they have much difficulty in metabolizing folic acid, and that individual is going to need 5-MTHF. Otherwise, the baby will malform and there'll be neural tube defects that take place. Okay, so here's the cranial nerve. It gives you the nerves, the name, their functions. Make sure you know them by name, by cranial nerve, and their functions. CVA, cerebral vascular attack, which is a stroke. These can be ischemic due to a blood clot or decreased blood flow, or hemorrhagic due to a rupture. Some of the risk factors are high blood pressure because the blood pounding against the endothelial lining or the epithelial lining is very weak. Not just high cholesterol, it's got to be really high, like 323 or better. That's when we really start to see problems. But there has to be oxidized LDL, or heart disease, high blood sugar, smoking, obesity, and alcohol. These are all risk factors. If someone is having a stroke, then calling 911 and getting them to an emergency room immediately so they can give the individual TPA, which is tissue plasminogen activator. As long as it's used within the first few hours, it decreases the chances of permanent disability. When they have a TIA, a transient ischemic attack, it's where they have temporary impaired blood flow to the brain, and they have just a really quick burst of either dizziness, slurred speech, numbness, double vision. The treatment here is typically aspirin or anticoagulants, but these typically do not have any residuals. They don't last very long, but it's a really good indicator that a major stroke is on its way, and they really need to get assessed. Alzheimer's or dementia is the loss of reasoning, the ability to read, write, talk, eat, and walk. It affects, more than 10% of the population over the age of 65. And there's loss of neurons that release acetylcholine. And we know acetylcholine is a very, very important neurotransmitter to the central nervous system. And risk factors are head injury, also hereditary. And another risk factor now is high blood sugar. Because if you look at Alzheimer's, you'll hear of mention of type 3 diabetes. But there are some beneficial effects of estrogen and vitamin E, ibuprofen, ginkgo biloba. There are some benefits there. Aging, natural aging is going to be loss of neurons, the diminished capacity of sending nerve impulses to and from the brain, diminished ability to process information, maybe a little bit slower, decreased conduction velocity, slowing of voluntary movements, reflexes slow down, and the degeneration in vision, hearing, taste, smell, touch, and balance. These are all signs of a dysfunctional, degenerating brain. And when the brain starts to atrophy and dysfunction, the body starts to break down as a result. And the individual, we typically say they're in transition or, they're on their way out. Displacement or distortion of tissue at impact can cause brain damage, increase of pressure, infections, free radical damage, concussions, contusions. Concussions are usually traumatic brain injuries, a temporary loss of consciousness, or they just get headaches, they feel confused, they can't concentrate in class. A contusion is a bruising of the brain, less than 5 minutes of unconsciousness, but there's blood in the cerebral spinal fluid. And of course, a laceration, some sort of tearing of the brain due to a fracture or bullet, or increase of intracranial pressure from an accumulation of blood from a hematoma. Okay, that was a lot of information there. We hope you enjoyed that.